Hello, everyone. I would like to begin by acknowledging the land that I'm coming to you from today, which is Treaty 4 territory, the traditional territory of the Cree, Saulteaux, Lakota, Nakota, and Dakota people, and the homeland of the Métis. My name is Kelly Lerat, and I'm a proud member of Cowessess First Nation, also located in Treaty 4 territory in Saskatchewan. My passions lie completely within the field of Indigenous public health, and I was very lucky to continue this passion further in my practicum placement with the National Collaborating Centre for Indigenous Health, the NCCIH. The NCCIH is one of 6 national collaborating centres in Canada, and it's unique in that it's the only centre that focuses on a specific population. The NCCIH aims to renew a public health system in Canada that is inclusive and respectful of First Nation, Inuit, and Métis peoples. I would like to thank my practicum supervisor, Dr. Margot Greenwood, the NCCIH manager, Donna Atkinson, for all of their guidance and support throughout my practicum. My presentation today will focus on my gaps and trends analysis project with the NCCIH. I would also like to thank Jeff, Dr. Buringer, who is my second reviewer, the entire PHSP faculty and staff, and my peers in the MPH program for all of your encouragement and support throughout the program. So before I get into the specifics about my project, I wanted to give a brief overview of anti-Indigenous racism in Canada and why cultural safety is an important piece to addressing this issue. So in Canada, Indigenous specific racism is deeply rooted within colonialism. Anti-Indigenous racism is the ongoing discrimination, stereotyping, and injustices experienced by Indigenous people. It includes the ideas and practices that contribute to establishing, maintaining, and perpetuating power imbalances, systemic barriers, and inequitable outcomes that stem from colonial practices and policies. So this living legacy of colonialism underpins the very structures of our health system. From a population and public health perspective, the intergenerational impacts of colonialism and racism on Indigenous people's health is evident through the inequities experienced by Indigenous populations across the determinants of health. So compared to the general Canadian population, the burden of disparity on nearly all markers of health is greater among Indigenous people. This includes overcrowded or inadequate housing, barriers to accessing post-secondary education, reduced economic resources, and increased risk of food insecurity. The health system, which is built on colonial underpinnings of racism, also negatively impacts health outcomes through discrimination that is experienced by Indigenous people at point of care. Longer wait times, fewer referrals, and disrespectful treatment of Indigenous patients not only causes emotional and social harms, but it also creates long-term impacts where Indigenous people lose trust in the healthcare system, leading to low usages of health services. So creating a health system that is culturally safe is essential to improving the health outcomes of Indigenous people. The concept of cultural safety was first developed for use in nursing education in the 1990s in New Zealand, and it has since been adopted within healthcare in Canada. So traditionally, cultural safety occurs at the front lines of healthcare, where health professionals reflect on their own cultural and social positions and how those impact their relationships with clients from different backgrounds. However, cultural safety must be practiced at an institutional level to allow space where respectful interactions between individuals can occur. The project I completed with the NCCIH was a gaps and trends analysis report of their cultural safety resource repository. So this repository is located on the NCCIH website, which is accessible for free to the public. The repository is intended to support practitioners working in Indigenous communities and public health researchers and policymakers. So my analysis included a total of 358 resources in the repository, and I looked at 6 different characteristics. The majority of the resources were from external sources, and these items were gathered by NCCIH staff over several years as they worked on a couple different projects that had a cultural safety focus. So the resources included is not an exhaustive list of all cultural safety resources that may exist outside of this collection. So in my analysis, I found a lot of interesting findings, and I'll share a few key highlights here with you today. So in terms of format, I found 16 different types, which included reports, policies, tools, videos. The most common format identified was journal articles that represented over a quarter of the overall repository. The fewest formats found were podcasts, presentations, and posters. In terms of focus area, all of the resources in the repository had a cultural safety focus, but this characteristic looked at additional focus areas of the resources such as health, child welfare, education, reconciliation. So the large majority of the resources, no surprise, was a health focus with a total of 288 items. Anti-racism resources counted for 14, and justice-focused resources had the fewest at 2 items. So with the previous 288 resources that were identified as having a health focus, these were further subcategorized into specific health topics. A total of 15 health topics were found, and the most common was health services delivery. For geographic location, approximately 84% of the repository included resources specific to Canada, with the province of BC covering almost 25% of all Canadian resources. Quebec had the fewest at 2%. For the reference population, about 58% resources were targeted to the overall Indigenous population, whereas Inuit-specific resources accounted for about 1% of the repository, and Métis-specific accounted for about 0.6%. For the intended audience, the majority of the resources were intended for healthcare providers with 234 items, and for reference, public health practitioners had about 77 items. Service providers had the fewest, and this group was categorized as providers that are outside of the health field, such as a social worker, and they had 34 items. So based on these findings from my analysis, I developed considerations for moving forward for public health practitioners. This figure here in the slide is Dr. Greenwood's framework for creating change, and it describes how actions across structural, systemic, and service delivery levels are required for successful and long-lasting change. And I'll be using this model to situate my considerations. So starting with the outer layer, the structural level represents high-level legislation, policies, and agreements that act as structural enablers of change. So in order to uproot Indigenous-specific racism in the health systems, it requires a shift in governance, leadership, and legislation. Cultural safety needs to go beyond the responsibility of the individual health professional and into the very structure of institutions. As public health practitioners, we need to continue to advocate and evaluate these efforts and ensure Indigenous partners are included at all stages and all levels of the policy cycle. The second layer of the model is systemic change that represents systems, organizations, and programs. As individuals, we must reflect on our own personal biases, attitudes, and beliefs that impact the services we provide to Indigenous people. Organizations must also participate in this self-reflection on their policies, their procedures, and their practices that impede or improve culturally safe environments within their organizations. So public health practitioners have key roles in leading this policy-based action for change to support culturally safe practice at the service delivery level. So, and at the center of this model, we have service delivery, where the promotion of culturally respectful and safe practices between Indigenous and non-Indigenous people is very important. So fear and lack of trust in frontline workers and in the health system was found to be one of the biggest issues in BC's health system from the 2020 In Plain Sight report. And in fact, many Canadians are still unaware that the colonial institutions they work for are set up to systematically marginalize Indigenous people. So moving forward is important for public health practitioners to have continued and increased educational opportunities that include foundational training in colonialism that impact racism on the health and well-being of Indigenous people. So in 2019, the Chief Public Health Officer's report on the state of public health in Canada highlighted stigma as a public health issue. The implications this project had on public health highlights the continued need to embed cultural safety, not only within service delivery and practice, but within the systems and structures that underpin our public health system in Canada. Cultural safety moves from focusing on differences to responding to the health implications of colonialism and work to dismantle the power hierarchies that exist within the health systems. So cultural safety is required at all levels of public health practice, and we must continue to privilege Indigenous knowledges and allow it to shift our approaches and practices in order to create sustainable change in a safer public health system for all. And thank you so much for your time. And if there are any questions, I welcome them now.